Many a time we see rheumatoid arthritis patients on DMRD coming with a flare and especially monoarticular flare. When a single swollen joint is causing the flare, it's a clinical emergency in RA unless proved otherwise, because RA flare needs immunosuppression. It could be septic arthritis which need urgent antibiotic with or without drainage, and without treating infection it can be life-threatening. So RA joints are structurally damaged, immune suppressed due to the treatment, so they are at high risk of joint injury and infection subsequently. So monoarthritis should be presumed as septic unless proved otherwise. The clinical clues are sudden onset, severe pain, associated fever are all favoring a septic arthritis. Well, the joint pattern in infection and flare, usually number of joints is 1 or 2, but in flare usually it's a polyarticular. So monoarthritis, single arthritis, joint arthritis is suspicious. Especially when recent steroid use, underlying diabetics, or an overlying skin infection or prosthetic joint is involved, think of septic arthritis. The systemic clues are the inflammatory clues are leukocytosis, high CRP, high ESR, but CRP alone cannot distinguish between these two. So you need a synovial fluid, which is a gold standard. So infection will have a very high synovial count with more than 90% neutrophils and gram stain positivity, and when culture done, it usually yields if it is a septic arthritis. So imaging may not differentiate between these two, a flare of rheumatoid arthritis and a septic arthritis. So ultimately the treatment decision should be based on whether it's a septic arthritis, whether antibiotic and drainage. If it is a flare of RA, you can increase the immunosuppression. So any new hot monoarthritis in a RA on DMRD is septic until proven otherwise. Put in a needle, take the fluid, do the cytology, and discriminate between these two.